And with that, we can get started. So today we'll be talking about medical interventions, and I'm going to hand it over. I'll first start with some disclosures.
So while this presentation might include some images of medications, they're more to give an idea of what exists than to sort of advertise these medications, and no product is paying to be here, and we don't really necessarily approve one trade name over any of the others. Yep. And then the business. As well, and Pritzker M4, Lily Lair also contributed to some of the slides. So,
And
yep.
then this is a brief outline of what we're going to go over today. We're going to start with talking about hormone replacement therapy for adults, puberty suppression for adolescent and pediatric patients, and some reproductive health considerations. And I'll hand it over to Johnny.
All right, guys, welcome. Thank you all for being here today. Yes, we're going to be discussing hormone replacement therapy. And really the main takeaway from here is to really get you guys walking away with some of the big concepts as far as, some of the different things that we use for feminizing gender-affirming hormone treatment, as well as masculinizing gender-affirming hormone treatment. So just generally, what is hormone therapy? It's an adjunct for transgender patients to produce physical changes in the body. These are typically referred to as secondary sex characteristics that better help patients align the body with a person's gender identity. Typically, the criteria for patients on hormone to receive hormone replacement therapy for all medical intensive purposes, as well as insurance, patients typically have to have gender dysphoria diagnosed, which we kind of talked about in the previous workshops in order to be approved to be on treatment. Patients have to have the capacity to make an informed decision for the treatment. And typically the age is 18 plus for in the US as well as most countries. For any patient under 18 classified as a minor or adolescent, typically parental consent is required. As long as there are no other significant medical or mental health concerns that are present that may make it for a patient to be on hormone replacement therapy, typically have to be well documented or controlled. Next slide. So discussing a little bit more about feminizing gender-affirming hormone treatment. Typically, just a nice overview, main point here for patients is the development of female secondary sex characteristics with a minimization of masculine secondary sex characteristics. And it typically involves a combination approach of estrogen as well as an anti-androgen blocker. Next slide. So what are kind of some of the big common side effects or big effects or changes patients can expect to see with feminizing hormone therapy or estrogen-based hormone therapy? The big one here is breast development, the manifestations of breast development, redistribution of facial and body subcutaneous fat for patients transitioning from male to female, reduction of body hair or facial hair to a lesser extent. But patients may also experience changes in their sexual function, such as changes in their libido, reduction in testicular size, as well as sperm count. And this is kind of an image on the right here showing you some of the other physiological changes. Next slide. So the main kind of mainstay for feminizing hormone replacement therapy is estrogen. And typically, though, for a lot of patients, estrogen alone is not enough. And so typically, that's paired up with another medication, typically an anti-androgenic therapy that's commonly added. And the reason for that being is that sometimes estrogen at very high doses can create a lot of side effects. So when you pair it up with another medication, you reduce the amount of estrogen that the patient may need, thus reducing the amount of potential side effects that come with estrogen. And typically for patients that may have like any contraindication to being on estrogen, this is also another great alternative for patients. So what are kind of some of the different forms of estrogen? Estrogen comes in many different forms. There is an oral form, which is equivalent to the biological hormone 17-beta estradiol. There's obviously a subcutaneous and intramuscular form. And then there's another form, a transdermal form. And this is typically for patients where an oral form or a sub-Q form may be contraindicated due to some of the side effects, such as, estrogen is known to potentially for patients with like cardiovascular or hypercoagulable disorders cause clots. And so transdermal form may be a better alternative if those are some of the risk factors. So typically the form that patients use, although most commonly oral sub-Q, will vary depending on some of the patient risk factors. Okay. And next slide. So what are, again, some of the common contraindications to being on estrogen therapy? You know, the table on the right lists a whole some of different complications, but the really big ones that are kind of like considered absolute contraindications are patients that may have unstable ischemic cardiovascular disease, again, that risk of potentially causing a stroke or a clot, as well as elevated hypertension. Having liver disease, again, because estrogen is typically cleared out by the liver. Or any type of cancer that may be estrogen dependent or responsive to estrogen, right? That's going to worsen their cancer. But typically the important thing really here to keep in mind is that, yes, there are various categories of contraindications, but part of that is also, as a clinician is weighing the benefits and the cons, right? Because hormone replacement therapy is known to be a life-saving treatment for patients. And so studies have shown that it reduces suicidality. It reduces the symptoms of gender dysphoria. And so you really have to weigh the cons and the benefits. And so while these are absolute contraindications, they're not necessarily, you know, textbook absolute contraindications. The alternative of some of those other impacts that I spoke about could outweigh those. Okay, next slide. And then I discussed briefly anti-androgens. Really, the main point of anti-androgens is to reduce testosterone levels, and so that helps diminish masculine characteristics such as body hair. And that combination is helpful, especially when used with estrogen to suppress testosterone levels, as well as reduce the amount of estrogen dosing that may be required. Some of the different types of anti-androgens. Next slide, please. Most common being spironolactone. I'm sure some of you guys may have heard of spironolactone in medical school, but it's a potassium-sparing diuretic. And then at high doses, it has an anti-androgen receptor activity and can suppress the effect of testosterone. Some of the big side effects to look out for this is hyperkalemia, as well as just monitoring their patient's blood pressure and electrolytes. Next slide. Another type of anti-androgen here, I just kind of wanted to discuss it because you may have heard about it or seen it in passing, or if you happen to do your research online, is known as cyproterone acetate. This is not a form that's commonly used in the United States, but it is used in some parts of Europe as well as other countries where other various forms of anti-androgen aren't available or more expensive. This really isn't approved and not commonly used at all in the United States, just because it's been widely shown to cause hepatotoxicity. But I just wanted to mention it in case it was something that you might have seen this name or drug before. And then other forms of anti-androgens would be gonadotropin-releasing hormone agonists. So again, these block the GnRH receptor, which in turn then block the release of follicular-stimulating hormone or luteinizing hormone. These also can be a great alternative to use. Typically, though, more expensive than other forms like spironolactone, as we mentioned. But just a notable mention, they typically come in an injectable or an implant form. And lastly, you have your 5-alpha reductase inhibitors, so finasteride, dutasteride, and these really block the conversion of testosterone to 5-alpha DHT, which causes those secondary sex characteristics. And so typically the benefit for these is that it helps to reduce scalp hair loss, especially for patients where, again, hair identity is a very important thing for patients that are transitioning, as well as suppressing body hair growth, being the two most common things. Next slide. And here's just a really nice general overview of what patients can expect when going on estrogen or an anti-androgen therapy. Some of the most common changes that typically take place are related to the skin, but as well as you start to see breast growth development within 3 to 6 months. Sexual changes such as decreased libido typically happen within the first month, and as well as a decrease in the sperm count. But as you can see here, Most of the changes are reversible, or if patients choose to discontinue treatment. The only one that after 3 to 6 months is breast growth. So typically once patients experience breast changes or breast growth, that typically is difficult to reverse once those changes have started. Next slide. And as far as just monitoring for patients on feminizing hormone replacement therapy, typically hormone levels are measured every 3 to 6 months, be it the testosterone as well as their estrogen levels. And that's really to make sure that patients are meeting their target goal that was set out. But then typically, as well as looking for physiological changes and physical changes in the first 3 months, typically, after the first year, patients only need monitoring every 6 to 12 months. Again, as I mentioned, if patients are like on spironolactone, monitor those potassium levels. Another big thing to consider as well is bone mineral density, especially for patients at risk of osteoporosis, as well as making sure you're screening for breast and prostate cancer. And that's it. With that, I'm going to hand it over to my colleague to discuss about masculinizing gender-affirming hormone therapy.
Okay, thank you, Johnny. So I'm going to talk about the other side of the coin regarding hormone replacement therapy. Masculinizing hormone therapy is basically the opposite of what Johnny just talked about. The goal is to develop male secondary sex characteristics and minimize the development of or minimize female secondary sex characteristics. And generally, there's just one medication, it's testosterone. Some of the common effects you can expect from masculinizing hormone therapy include facial hair, voice changes, and also some dermatologic changes such as acne or oily skin, which Johnny will talk about later. All preparations of testosterone available in the US are bioidentical to endogenous testosterone. So it just looks the same as testosterone that our bodies make. Synthetic forms of testosterone have fallen out of favor due to concerns about hepatotoxicity. And there are multiple modes of delivery, which I'll get into shortly. And one important thing to note is that higher dosages of testosterone may be required for trans and gender nonconforming patients compared to male patients. Non-transgender patients, sorry. Some forms of testosterone include the oral form. This is more common in Europe compared to the US because of concerns about concerns about first pass effects. This results in a lower serum testosterone compared to some of the other forms I'm going to talk about. More common in the US are injections, so that can be intramuscular or subcutaneous. These are typically administered every 2 to 4 weeks, and patients might notice some cyclic changes depending on when their last injection was. And with all of these formulations, it's important to spend a lot of time at the beginning of initiating treatment, titrating the best dosage of testosterone to meet a patient's goals. And then the final form of testosterone delivery is transdermal. This is available as both a gel and a patch that are applied daily. The time frame in order to achieve clinical effects for these preparations might be a little slower compared to, say, injections. And as with any medication, the goal is to use the lowest dose possible in order to maintain the desired clinical result.
Yeah, so I'm going to jump in and talk about some contraindications and risks of testosterone therapy. So as a general caveat, it's important to keep in mind that access to hormones is something that's very life-saving and life-affirming for patients. And with informed consent, it's possible to have a conversation about initiating hormones in patients with higher risk profiles when chance of survival and quality of life outweighs the risks of treatment. And there are some of the general risk factors on the side, but some of the absolute contraindications to testosterone therapy, like even in these cases, are pregnancy or breastfeeding, active endometrial, breast, or androgen-sensitive cancers, serious cardiovascular, hepatic, or renal diseases, as well as any hypersensitivities to components of the formula. And then this is sort of a similar graph to the graphic to the one about estrogen. So just talking about timeline of the effects being on these sort of regimens. So there are several irreversible sort of effects of testosterone. These can be hair loss, voice deepening, hair growth, and clitoral enlargement. Reversible changes can include skin oiliness and acne, increased muscle mass and strength, as well as vaginal atrophy. And usually the first thing that patients will kind of notice is changes in their skin, sort of around 1 to 6 months of being on treatment. But things like fat redistribution, hair growth, clitoral enlargement, and atrophy might take a couple of months to start, but can keep changing anywhere from 1 year to 5 years of being on testosterone. So it's important to have continued conversations about the effects that patients are experiencing. As well, there's some monitoring that goes along with being on testosterone. So before initiating a regimen, it's important to know serum testosterone baseline, as well as hematocrit and lipid levels, as well as bone mineral densities for patients at risk of osteoporosis. For screening, within the first year should be done every 3 months, and then after the first year, every 6 to 12 months for adverse effects, potential virilizing effects, as well as patients with cervices and breasts should get their appropriate screening in terms of breast screening, cervical checks, things like that. And I'll toss it back to Johnny.
Thank you. And thank you so much, Leah. And so what we this slide really here, what we wanted to show you is that particularly for a lot of patients, especially patients on testosterone therapy, will experience, a lot of the times the first manifestation is related to their skin or some skin changes. And so typically within just the first couple of weeks or month, patients can develop kind of this image on the left here showing what is pseudofolliculitis barbae. And this is just basically a cutaneous inflammation of the hair follicles. And typically for a lot of patients, this can be from head to toe. On the right side, patients can also develop cystic acne, and the acne can be also very severe, as well as the middle picture here showing lichen sclerosis, which is much more common for trans feminine patients, which typically presents as this like crinkled, thickened patch of skin that's very itchy and tender, a lot of times in the anogenital region. And the important thing about this is that, as we discussed before, for a lot of patients, especially during the process of transitioning, a lot of the skin manifestations or ongoing cycles of having a period, for example, can be very debilitating, and it can induce a lot of symptoms of either PTSD or psychological distress as they are transitioning. And so a lot of times, when patients are undergoing hormone replacement therapy, managing some of those manifestations can really help alleviate some of the symptoms associated with the diagnosis of gender dysphoria. And typically, in the past, for especially transmasculine patients, getting on isotretinoin through the iPledge system was very problematic, because a lot of times patients will get referred to a dermatologist. But that has been corrected more or less now because of those issues. It used to require that patients needed, 2 forms of contraceptive, and this was problematic for transgender males. But I just wanted to give it a notable mention, and in turn, I will hand it over.
Thank you. Now we're going to switch gears and talk about the pediatric and adolescent patient population. The mainstay of medical treatment for trans pediatric patients is puberty suppression. The goal of puberty blockers is essentially to press a big pause button on puberty. So essentially it prevents the development of unwanted secondary sex characteristics by delaying the onset of puberty. So eventually these patients will get off puberty blockers and go through puberty. But the main goal of puberty blockers is to buy time so patients can think about what they want for their lives and what they want in terms of transitioning, and not have to rush through things. And the main approach of puberty blockers are gonadotropin releasing hormone analogs, which Johnny talked about previously. The effects of these treatments are reversible and are also used in a lot of other medical conditions, such as precocious puberty or endometriosis. This is just a little background on how GnRH analogs work. So in the body, GnRH is part of this hypothalamus pituitary gonadal axis, and GnRH in the body tends to be released in a pulsatile fashion. And when it's released in a pulsatile fashion, it activates the production of androgens and sex hormones. However, when GnRH analogs are given continuously, such as in puberty suppression, it instead of activating, it actually inhibits the production of sex hormones. And that took me like a while to understand, so I just wanted to talk through some of the pharmacologic mechanisms of action of these treatments. In terms of timeline of treatment for these patients, a lot of pediatric patients may socially transition first, and you can start the conversation about puberty suppression early, but generally these patients start taking these medications around 10 to 11 years old, or when they exhibit Tanner stage 2 and detectable luteinizing hormone levels. It can also be started later, I think in patients like up to like 14 or 16. And generally, these patients will discontinue puberty suppression around 14 to 16 years old, and they can go on to pursue like further gender affirming treatment, such as hormone replacement therapy. And in fact, the majority of patients who are on puberty suppression do continue to pursue gender affirming care in adulthood. And on the right, you can see just a little timeline about when patients might start puberty suppression. Obviously, there's a range of times in which this can be started, but optimally it's around like 11 years old or so. GnRH analogs are available in a variety of formulations, mainly injections or an implant. The injections are typically given monthly, every 3 months, or every 6 months, such as Lupron. There's also a daily injection, leuprolide acetate. And then finally, there is an implant called Suprelin. It kind of looks like Nexplanon, if you guys know what Nexplanon is. It's inserted under the skin, and it is generally good for about 12 to 36 months. Obviously, when you are treating pediatric patients, you want to make sure they're growing well. So there are a number of factors to consider in terms of monitoring patients who are on puberty suppression. So you should monitor their height and weight, their pubertal staging, their luteinizing hormone, and their natal sex steroid levels. Generally, a therapeutic luteinizing hormone level should be like undetectable or at least less than 0.6. And then these treatments can also impact growth, so it's important to monitor patients' bone health via bone mass measurements. And then there are some recommendations in terms of monitoring patients in the table on the right. There are some potential side effects with puberty suppression, as with any medication. Thankfully, the majority of side effects are quite mild. The most common includes injection site reactions. When patients are initially starting GnRH agonists, they might notice some changes such as changes in mood, acne, testicular pain, or vaginal bleeding. And this is because the first dose will transiently stimulate gonadotrophs. However, after a long period of time, those changes should settle. There might be some growth spurt suppression, but again, these treatments are intended to delay puberty. So when patients get off these medications, they should go through puberty and grow. And there is concern about lower bone density, which is why people recommend monitoring bone health in patients on puberty suppression. One unfortunate sort of economic factor in terms of puberty suppression is that GnRH agonists can be expensive and are not always covered by insurance. In a study I found that was published in like 2015, there was a pediatrician, I think at Boston Children's, and only like a fifth of their patients who were on GnRH agonists actually had it covered by insurance. So I was looking into some lower cost alternatives to GnRH agonists, and some include progesterone acetate or Depo-Provera. This is effective for patients both assigned male at birth and assigned female at birth. It is less effective compared to GnRH agonists, but it is low cost and it's available in both an oral form and an injection. And another alternative is spironolactone, which is an anti-androgen that can be used in patients who are assigned male at birth. And
yes, quick, before we go on to reproductive health, I had somebody send me a question. So the question I was sent asked if a question about hormone replacement. How long do patients tend to stay on hormone replacement therapy?
Yeah,
Yes.
that's actually a really great question. So this one is it's a mixed bag because it's dependent patient to patient, but to kind of like answer the general question of do patients sometimes need to take hormones and for how long is typically for the rest of their life, and that's typically to either like maintain the feminizing effects of the estrogen or the masculinizing effects of the testosterone that they're on. But some patients at one stage or another may elect to, for example, have surgical intervention, such as either having their ovaries or testes removed, just because typically the effects of the hormone is to cause suppression of either the ovaries making estrogen or the testes making testosterone. But for most patients, like they'll see physical changes within the first year to two. And then while they may need to be on estrogen or testosterone to maintain the maximum effect of those secondary sexual characteristics, for some patients, they may need to discontinue just because of risk of adverse effects related to estrogen later on in life. Or for most patients, this is typically just readjusted down to a much lower daily dose that's manageable and doesn't really pose as much side effects. So that's a great question. Typically, the answer is for the rest of their life or as long as the patient wants to keep taking them. But it depends just based on side effect profile and then patient comfort and what the patient wants to achieve.
Yeah, this actually sort of relates to this topic because I'm going to talk about some instances in which patients might want to stop taking hormones and what that might look like. So yeah, and that's reproductive health. So considerations for patients who are on hormones and might want to talk about their fertility. Yeah, so 25 to 50% of trans and gender non-conforming patients are parents themselves, as well as 50% of trans patients desire some form of fertility preservation. So it's important to counsel every patient about fertility preservation and their options prior to starting medical treatment, because there's some differences in what you can and can't do. As well, more research is needed to understand younger patients' interactions with fertility care and as well their priorities. In addition, something that we talked about is some forms of contraception can also be gender affirming, such as things like local contraceptive methods like the IUD that would stop menstruation, or methods like Nexplanon that would have a similar effect, or methods like the ring that would be local and also contraceptive. So yeah, in terms of puberty suppression and fertility, where I'll begin. So like Tiffany mentioned, GnRH analogs are used to delay puberty, and the effects of these are reversible, but also may have some impact on fertility potential. So in general, decreases in anti-Müllerian hormone would decrease testicular and or ovarian size. And studies are unclear about the potential for resolution of these symptoms after discontinuation, but for most patients, the effects of puberty suppression is reversible. As well, for testosterone is sort of the next step. For patients who are on testosterone, it can have ovulation suppressing effects. And this would lead to amenorrhea, which is reversible. Most menstruation returns within 6 months of stopping testosterone. So And as well, this like suppression of ovulation is not contraceptive. So patients can still ovulate but not menstruate, and individuals with intact ovaries and uterus on testosterone should use contraception, and barrier methods are usually recommended. As well, this is part of the reason testosterone is teratogenic, so it's important to avoid it in pregnancy. And in patients who are on testosterone and desire to become pregnant, this is possible. They would sort of go through the process of stopping testosterone. Menstruation would return, and then sort of the discussions about getting pregnant that people have when they're trying to with their doctors could sort of start. But it's very possible, and being on testosterone is not contraceptive and doesn't mean that you can't also get pregnant. And then estrogen is sort of the other class of medical therapy that patients might be on. So like Johnny said, estrogen suppresses gonadotropins, which reduces testosterone, and prolonged estrogen exposure has been associated with testicular damage. As well, like the restoration of this has not been well studied. So with patients that start estrogen that might later desire fertility, cryopreservation is recommended before the initiation of hormone therapy. And so there, like I mentioned, there are a bunch of options. So this slide goes sort of over options for transmasculine or gender diverse people assigned female at birth, and divides it sort of into two classes. Prepubertal patients can have ovarian tissue preservation, in which a sample of their ovarian tissue is saved for later fertility. Post-pubertal patients can have either oocyte or embryo cryopreservation, or in some cases uterine preservation, but this is less common. And then transfeminine or gender diverse people assigned male at birth, as well as sort of two buckets. Prepubertal patients can have testicular tissue cryopreservation, and post-pubertal patients can have sperm or embryo cryopreservation, which is the most common. As well, this is sort of more of a future direction. There have been cases studied of uterine transplantation in people assigned female at birth who are having just sort of reproductive concerns. And I think in 2019, there was a case study of a patient with a transplanted uterus who successfully carried a baby to term. So this is a potential for the future, but I don't think it's been studied in transfeminine individuals, this sort of thing. So future directions.
This is just a little summary slide of what we talked about today, and then we have a case. It's sort of interactive, so we would love if you could participate in our case discussion. So today we talked about a variety of medical interventions for trans and gender diverse patients, including hormone replacement therapy, puberty suppression. We noted that reproductive health is really important for this patient population before starting any sort of medical interventions, and that's something you should discuss with patients. I want to note that the things we talked about today are not exhaustive at all, and that there are many, 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 many options. And if you're interested in learning more, we recommend taking a look at the WPATH standards of care, which you can Google or I can send a link to. And in general, just empower your patients to make informed decisions about their care.